our questions in an organized manner. So today's topic is going to be understanding the difference between chemo and immunotherapies. And as a newly diagnosed patient, or even if you're a myeloma patient or caregiver that's further down in your myeloma journey, understanding the different therapies that are being suggested or even thrown at you can be overwhelming. There's currently buzz around immunotherapy as it's really exciting, using your own immune system to attack the myeloma with potentially less side effects. I'll let Dr. Goldsmith talk more about that. I just am excited about immunotherapy. But sometimes, what does that even mean? And how does it differ from chemotherapy? What types of myeloma fighting drugs are classified as chemotherapy, which are classified as immunotherapy? Trying to understand and navigate this myeloma arsenal that we have to fight the disease can be quite overwhelming, which is why I invited Dr. Goldsmith here today to give us more information on this subject. And it's now my pleasure to introduce him to you. Dr. Scott Goldsmith specializes in the treatment of multiple myeloma, which is also the focus of his prolific research. He's passionate about bringing new and innovative treatments to patients with multiple myeloma and other hematologic malignancies through translational research and clinical trials. He entered medicine because he remembers how well he was treated when he was a patient in his teen years. He felt firsthand the profound, lasting impact that healthcare professionals can have on an individual. He credits his experience with informing the way he practices medicine today. He listens carefully, communicates clearly, and understands who his patients are as people. And he even shared with me he has groupies now at City of Hope, and you can see why if he's so passionate about his treatment of patients. He's a Florida native, and he graduated with honors from the University of Florida, and then earned his medical degree at UF's College of Medicine and continued his training at Barnes-Jewish Hospital, Washington University School of Medicine in St. Louis. He takes pride in the relationships that he forms with his patients and is intent on making an impact at an individual, institutional, and global level in finding better treatments, as we mentioned, for multiple myeloma. He loves City of Hope, and it's an ideal place to be for him as he can contribute to these missions and make this possible. So, Dr. Goldsmith, you're an amazing doctor. We're excited to hear from you today, and the time is now yours.
Awesome. Well, thanks again, Audrey, for introducing me, inviting me back to speak with you all. It's awesome to see familiar faces as well as meet some new ones. This is really an amazing program that you all have instituted in a relatively short amount of time to be able to help educate myeloma patients who are really thirsty to be educated and understand what it is that they're going through and the treatments they're receiving, and have a real much stronger grasp in regards to their diagnosis. And so I'm happy to be a part of this, and I once again appreciate the invitation. So let me pull up my slides here. And so as Audrey was kind of saying, with all of the therapies out there for myeloma, it can be incredibly overwhelming. We've got chemotherapies, we've got novel therapies, which aren't exactly chemotherapies, and then we've got the shiny, bright immunotherapies that are out there and everybody wants to grab a hold of. So I wanted to take these 30 minutes or so to get a much better understanding of where we've come from, what the therapies are that we have, the mechanisms behind them, why we use them together, and then put them into context as to how we use them for patients, how we sequence them, and how we might sequence them in the future. So we'll start with a timeline of the myeloma therapy development, as well as the impact that it's had on myeloma patient care. I'll go through the different classes of medications, and then also why they work and how they work, and then how they overlap with one another. These aren't discrete classes. There are some therapies that can fall into both immunotherapy and chemotherapy, or immunotherapy and novel therapy. So I'll highlight that as well. And then I think what will really be hopefully helpful is if we walk through a couple of patient cases where we've used these treatments, and when we've used these treatments, and why we use these treatments, and see how these could be employed for the care of people like you. And then, of course, we'll finish off with questions and answers, and I'm happy to answer whatever I can in the time that we have allowed. So I think this is a really impressive graph. This is in a recent review of immunotherapies and other therapies that we had. And if we look 50 years ago, there were hardly any treatments for myeloma. And we can see that the outcomes for patients at that time were pretty dismal. But we've been so fortunate that over the course of the past 50 years, we've seen continued development in drug therapies. And it's not only the innovative and intelligent people that are behind this, but it's the contributions that patients have made themselves to allow themselves to be part of these clinical trials that has allowed for such monumentous developments that we've seen. And so I think this arrow here is really going to start pointing almost straight up to the point where we can call people functionally cured. I think that we're going to see that in the lifetime of my career and in the lifetime that you all are going through myeloma treatment. So I'm really excited about where things have come and happy to be a part of that. And what we've seen, at least with myeloma therapies, is that historically we kind of build upon successes. So we take therapies that have worked and we add something to them. And it almost becomes this alphabet soup where we're just putting letters together and adding another letter. And so we go from doublet regimens to triplet regimens, and then triplet versus triplet, and then we add a fourth, and it's like, when will it end? But there's some reason behind this, because these drugs work differently. The side effects they don't overlap, and they actually synergize. We get instead of a 1 + 1 = 2, we get 1 + 1 = 3, or 1 + 1 = 4, and that's really what you go for when you're targeting myeloma. But this makes it really complicated. And so you go from, just 2 drugs to choose from to this whole arsenal of medications that we have available. And then, so you actually do need people who specialize specifically in the treatment of myeloma to understand when we use them and how we use them. And so it's nice to be able to work with myeloma experts and communicate with community physicians and kind of come up with a plan, because it really takes a team approach when it comes to understanding all of these different treatments and how best to use them. We really are not in Kansas anymore. So to kind of go from overwhelming to more overwhelming, I want to move on to the meat of this talk, where we're going to talk about the mechanisms of the drugs that we have and why we use them and how we combine them. And so hopefully when you are, going for treatment, you feel a little bit more empowered and understanding of what it is that you're receiving, so that you can feel informed and comfortable with the treatments that you get. And then also having a sense as to, if something comes next, what that might be. So I'll start first with conventional chemotherapy, because this is this is where we started. This is the old school chemotherapy that people know, and it has, kind of a notorious name behind it, but it definitely has some use. And we've gotten so much better at the support that we need for when patients need true chemotherapy. And so how chemotherapy works, it specifically is targeting cells, cancer cells, that are in the process of dividing. That is kind of the tried and true definition of it. And why do we do that? It's because cancer cells divide more often and more frequently than normal cells. That's how they become cancerous, essentially. It's their definition. And so we can target that by 2 main mechanisms. One is to basically affect their machinery that allows them to divide. So they have these little tubules that help split the tumor in half, so we can inhibit that. Or we can damage the DNA of the cancer, and that will then lead to cell death. So those are kind of the mechanisms for true chemotherapy. Of course, when you use these type of mechanisms where you're inhibiting dividing cells, you may also affect healthy cells that are more likely to divide. These tend to be things like the bone marrow cells, the blood cells, as well as the GI cells. And so that's why the side effects that we might see by using some of these therapies are related to those cells that divide. But like I said, we have gotten much better about supporting people through it. Some of the common uses of conventional chemotherapy in myeloma, the most common is going to be for stem cell transplants. where we use a high dose of a chemotherapy called melphalan to kill whatever we can of the myeloma cells. But that has the downside of killing some of the normal stem cells, which is why we then transplant back normal stem cells into patients. We do use some other types of conventional chemotherapies in the treatment of myeloma as well. But these were pretty much replaced, at least initially, with what we call novel therapies. Novel therapies are these really cool targeted therapies. They try to go after some of the elements of the myeloma cells that are really more specific to myeloma itself. So these are things that myeloma really thrives on. So for example, myeloma cells, as you probably know, secrete a lot of these proteins. We call them immunoglobulins, or that would be like your M-spike or your free light chains. They make a ton of these proteins. They're these like revved up factories. And so one that also makes them somewhat susceptible to interruption of those factories. So one of the staples, one of the workhorses of myeloma treatment, especially newly diagnosed multiple myeloma, is a class of drugs of novel therapies called proteasome inhibitors. And so what proteasome inhibitors do, there's this thing called the proteasome, which is almost like your garbage disposal for the cancer cell. So you have all this junk, all of these proteins that have been produced by the cell, and the proteasome can help break those down and allow the cell to survive. So what proteasome inhibitors do, and I'm in the process of trademarking this phrase, is they break the garbage disposal. They prevent the breakdown of these proteins, and as these proteins build up in the cells die. So that is why these proteasome inhibitors are so good in multiple myeloma. They cause all of those antibodies, those immunoglobulins, to build up in the myeloma cells and die. There are other mechanisms, but that's one of the main one. And so these are the three approved proteasome inhibitors for myeloma therapy, with Velcade or bortezomib being the one that's used probably most commonly in the upfront setting. This other one, Kyprolis, may get some use in the upfront setting in newly diagnosed treatment, but also in later lines as well, because they are so effective. None of the companies actually wanted to take this slogan, but I'm still pushing for it. So that is how this first novel therapy works for myeloma. There is another one that's also a workhorse of myeloma therapy, especially in the newly diagnosed setting, and that's these drugs called immunomodulatory drugs. And you see this word immunomodulatory and you think, well, doesn't that mean it's an immunotherapy? Well, to be honest, these IMiDs, as we call them, they kind of do a little bit of everything, and we're not exactly sure why or what. But the most common one that's used is lenalidomide or Revlimid. Oh, also you can kind of put it on everything. Basically, we combine these drugs with everything. Revlimid being the most common, Pomalyst, often used in later lines of treatment. Thalidomide, we don't usually use too much in the United States, but perhaps in Europe or other countries, it gets a little bit more use. But these drugs, these immunomodulatory drugs, function in many, many different ways. They prevent blood vessel formation to the myeloma cells, as well as to the support cells that support the myeloma. They activate some of the immune cells against the myeloma, and then they directly inhibit some of the signaling within the myeloma cells. So people might call the IMiDs and the proteasome inhibitors chemotherapy just for kind of simplicity's sake, which I think is fine, but they don't function in the same way as your old school chemotherapy. They're a little bit more targeted and they act differently, and their positive effects as well as side effects can be different for those reasons. But I think hopefully this gives a little bit of a foundation for understanding the two biggest drugs used in myeloma, which are their drug classes, and that's the proteasome inhibitors and the IMiDs. We do have a couple of other medications that are what I would call novel therapies. They don't act like chemo. This one, actually, Feradak has been taken off the market, but selinexor is one that's used in later lines of treatment, and it inhibits some of the channels that kind of pump drug out of the myeloma. So it would be considered a novel therapy as opposed to a chemotherapy. So immunotherapies, like I said, are kind of the bright and shiny new toy that we have with myeloma treatment. And I think really provide a lot of hope, as well as a lot of really a need for a different understanding of how myeloma treatment can work. So immunotherapies, in kind of a general sense, are treatments that are derived from the immune system and then use the immune system to attack the cancer. So you might ask, why do we even think to do this in the first place? Well, it turns out myeloma cells, as well as a lot of cancer cells, but especially myeloma, they have developed or evolved this ability to evade the immune system. They actually hide themselves from the immune system in order to spread and grow. That's how they go from those precancerous states like monoclonal gammopathy to myeloma. That's one of the mechanisms. They cloak themselves from the normal immune system. So what these immunotherapies allow for is they can actually unhide or uncloak the myeloma from the immune system and then direct the immune cells against the myeloma cells. They often work well combined with novel therapies, although some of the newer ones are being investigated and are very successful on their own. So we'll talk about the different, kind of the three main types of immune therapies here. The first, which maybe some of you have had some exposure to or some interest in, are the monoclonal antibodies. These would be most commonly daratumumab or Darzalex. The isatuximab is another one, and then elotuzumab is the third. And these first two, actually all of them target something on the surface of the myeloma cell. The next thing, which is not used in early myeloma, but later lines of therapy at this point, are CAR T cells. And we have two that have received FDA approval for myeloma therapy at later lines. And we'll go into details about the mechanisms and how these drugs work as well. And then something that's currently investigational, but likely to be approved within the next year, are these things called bispecifics. And we'll talk about the role and mechanism of those as well. So the monoclonal antibodies, what they do is they bind targets on the myeloma surface and then recruit elements from the immune system in order to kill the myeloma cells. So as compared to chemotherapy and novel therapies, which actually go inside the myeloma cells, what you have here is binding to the surface of the cells and then bringing in outside elements to kill the myeloma cell. So let's go over the anatomy of a monoclonal antibody or an antibody. And what you have is kind of this Y-shaped protein where you have two heavy chains connected each to two light chains. So it's almost kind of poetic if you think about it, because the myeloma cells produce their own antibodies that don't function and can sometimes cause harm. And so you might even be familiar with the term light chain. These are those same free light chains that you measure in your blood as part of following the course of the disease. So now we're kind of fighting fire with fire. We're using antibodies now to fight the myeloma, which I think is kind of cool. So what you have is this Y-shaped protein, and each part of this, the combined light chain and heavy chain, this portion right here, will actually bind to something, what we usually call an antigen, but it will bind to something such as the surface targets on myeloma. And so what this allows for is when you have this antibody, this monoclonal antibody binding to the surface receptors on the myeloma, it leads to a number of mechanisms of actually killing the myeloma. It can pull in these immune cells that can then engulf the myeloma or kill it. It can take things out of the blood called complement, which then lead to killing of the myeloma. And then it can actually cause intrinsic or cell death based on just altering the chemistry of the myeloma cell as well. So it's a powerful target that doesn't really overlap with any of the treatments that we've had previously. And so that's why it works well in conjunction with some of them. So this is kind of the foundation of myeloma immunotherapies, and probably the first with daratumumab and some of these other monoclonal antibodies. But we can build on that. We can take the antibodies and actually join, we can actually add these toxic, what we call payloads, so that these antibodies can then bind onto the myeloma cell and can deliver something that's toxic directly to the myeloma cell instead of that toxin going all throughout the body. So this has been developed, and there is an approved drug called belantamab or Blenrep, and essentially it's taking a antibody and conjugating or adding a chemotherapy to it. So then this binds to something on the surface of the myeloma. In this case, it's specifically BCMA. And once it binds, this chemotherapy is internalized into the myeloma cell. So it's kind of a cool way of taking a targeted immunotherapy and then delivering something directly to it. This is used in later lines of treatment, not in the upfront setting. And then something that we're going to be looking at here at City of Hope in a clinical trial, hopefully to open relatively soon, is can we join a radioactive isotope to daratumumab and deliver that same dose of radiation specifically to the myeloma cells. And so hopefully this will prove to be a useful way of combining immunotherapies with some of these other effective myeloma therapies as well. But probably what's getting a lot of buzz right now in the immunotherapy space for myeloma is the use of CAR T cells. So CAR T cells are something that's almost comes straight out of like a science fiction novel, because I don't know that anybody would have really thought that we'd be doing this 20 to 30 years ago. CAR stands for chimeric antigen receptor, and then T cells are one of the principal types of immune cells in your body that fights everything. It fights cancer, it fights infection. And they're almost like the generals of the army in your immune system. So what we do with CAR T cells is we actually are able to remove T cells from an individual, from a patient, and collect them. It's through a process that kind of looks like dialysis, but it's called leukapheresis. We then take those T cells and we send them to a manufacturing plant, our manufacturing center, where they're actually able to be genetically engineered to put this CAR, this chimeric antigen receptor, on the surfaces of a patient's own T cells. What they actually do is they take the genetic code for these CARs, put them inside the cell, and then the cell manufactures the CARs themselves, and they find their way to the surface of the cell. They then are able to expand them in the lab, send them back to us, where we are then able to reinfuse them into the patients. And so they end up, once in the patient, they end up finding myeloma, expanding, and are very effective at killing myeloma, even in patients who have had very resistant disease. So these are really very promising and exciting aspects to myeloma therapy, with a whole new host of positives and issues that we're learning to deal with as we study it and employ it more. So because one of the downsides, or one of the challenges with CAR T cells, is that we do have to take them from a patient and then have them sent off somewhere. And there's a turnaround time that is not insignificant, something that we have to factor in. So it would be nice also to have a newer immunotherapy that can use a patient's own T cells, but we can kind of pull it off the shelf. So what's in clinical development right now are these therapies called bispecifics. The most common form is what's called a bispecific antibody. So as I showed you beforehand, these Y-shaped structures are antibodies. And what some of the companies have been able to do in the lab is to take two different antibodies and almost hybridize them so that one arm binds the surface of a T cell, a patient's T cell, and then the other arm is able to bind the myeloma. And when they do that, they bring them close together, and the T cell can then once again recognize the myeloma as being bad and kill it. And I don't know if anybody expected them to be as effective as they're proving to be, but they are looking really promising with the ability of just pulling it off the shelf as opposed to the CAR T cells where you have to send them off to a plant for manufacturing. The one difference is that these are at this point administered indefinitely. As long as they're working like any other drug, we would continue it. These are, as I said, currently only in clinical investigations, but there have been some that are seeking regulatory approval at this point. So very exciting addition to the space. As I said, the myeloma therapies, some of them fall into discrete classes, and then some of them overlap one in another. So I created this Venn diagram as to where I think things kind of fit, where you have the novel therapies that don't really classify as chemotherapy, the old school chemotherapies that we sometimes use in multiple myeloma, with melphalan being the most common for stem cell transplant, all of the immunotherapies that have now entered the landscape with some overlap with the other types of therapies as well. This one is the one that's conjoined with, or takes an antibody and joins it to the chemotherapy. So I'll leave this here as a reference, and obviously these slides are available if anybody chooses to go back to them, just to reference it again. And there will not be a quiz at the end, but what I do want to do, now that I've given you just a really into the weeds course in myeloma therapies and the mechanisms behind them, I thought I'd try and put into context a little bit more as we go through some patient cases and see how we use these therapies, how we create cocktails of therapies that work well together, and in what type of patient we might use them, and then how we sequence them in patients who are going through different lines of therapies at different times. So the first patient is one of mine who's 59-year-old woman, otherwise healthy. She had hip pain and it was found to have multiple myeloma when she had multiple bony lesions. Fortunately, her kidneys were fine, and she wanted to really be aggressive with her treatment. She wanted to have as little evidence of disease left as possible. So we started with what's called induction therapy, which is to really kind of decrease the amount of myeloma tumors, improve symptoms, make it so as little myeloma is there in the first kind of aggressive treatment portion. And generally, we might do this in 4 to 6 cycles up front, where each cycle is 3 to 4 weeks. The regimen we chose, we called DARA-RVD. And so that's a combination of daratumumab, which is a monoclonal antibody. So now moving some of these immunotherapies to the upfront setting, to where we're treating patients up front. That's combined with an immunomodulatory drug. These drugs work really well together. They kind of give you that 1 + 1 = 3 scenario. A proteasome inhibitor, as I mentioned, we're kind of breaking the garbage disposal to really go after what the Achilles heel of myeloma, and a steroid, because we kind of give steroids with everything. But steroids do have anti-myeloma therapy or anti-myeloma treatments as well. So we went with that induction regimen. Then we proceeded to an autologous stem cell transplant. And here is where we use a conventional chemotherapy, high dose of melphalan, where we give 1 dose of, followed by a transplant of her own cells, an autologous stem cell transplant. And then this is somewhat optional. Some will do post-transplant consolidation, usually using the same regimen that they used before for some amount of cycles. This is kind of an evolving and occasionally controversial decision, but some will do that. And then usually after kind of a honeymoon period, we'll do what's called maintenance therapy. And that's with usually a lower dose of a drug we've used before. And Revlimid's probably the most common in that scenario. So this is one type of patient scenario that we might experience. This is another patient who was a little bit older, but he was healthy coming into things. He had newly diagnosed multiple myeloma, but this time his kidneys were impacted rather than having bone issues. And this actually caused him to need dialysis. So he wanted fairly aggressive treatment, and his main goal was to be able to come off dialysis. And this is often possible. So once again, we have been treating him with induction therapy, the first part to really debulk or get rid of as much myeloma as possible, because that's causing the majority of his symptoms and the majority of the problems. We used a different regimen this time called Cy/Bor-D. We used the Cy is cyclophosphamide, which is actually an old school chemotherapy, and that works well with bortezomib or Velcade. And the reason we chose this instead of using lenalidomide or Revlimid, as has been used beforehand, is that some of the side effects of Revlimid can be a little bit more pronounced in people who have kidney dysfunction and who are requiring dialysis. There are some that will still use it, but this was what was chosen for him. And then he went on to a transplant with the high dose of melphalan. We can use it in patients who are on dialysis. We did reduce the dose for it though. And then he's going to get maintenance therapy with Velcade instead of Revlimid once the time comes. So not everybody is going to proceed with stem cell transplant. Some decide that it's not for them. Others have a lot of health issues that prevent it, or they're of an older age and there's not as much data to support doing it. So this patient, who's almost in his 80s, he had bony lesions but didn't want transplant. He had so we have to think a little bit differently with these types of patients, where we're thinking, this is definitely more of a marathon where we want to treat the myeloma, sequence our treatments in a very thoughtful way, and it also make sure we're focusing on patients' values, especially in his case, quality of life was very important. So how can we do that? So with the first line, we used something called RVD Light, which is a little bit, it's using similar drugs that we'd used before, but on a different schedule at different doses. So it's a little bit easier from a side effect profile, and usually more tolerable to patients who are older, who have other treatment or other medical issues. His disease progressed, although not at a rapid pace. We were able to incorporate an immune therapy, daratumumab, in combination with another immunomodulatory drug, pomalidomide, and this was very effective. Now he's still doing fairly well on the treatment, but disease is starting to progress. So we explored what options there were, and there was a clinical trial using the bispecific antibody called teclistamab. This targets one of the same things that some of the CAR T cells target, although we didn't think that a CAR T cell was necessarily in his best interest because of the length of time it would take to produce it, as well as the chemotherapy that's required as part of it. So we had this option available to him, and he did quite well with that. And then the last patient who I'll discuss here she had first line therapy with the DARA RBD induction, went to a stem cell transplant, had maintenance with both DARA and Revlimid. Once she progressed, we incorporated that other proteasome inhibitor that I talked about in combination with another immunomodulatory drug. Beyond that, we used one of the other novel therapies I discussed in combination with a lower dose of Velcade to try and reduce the risk of the peripheral neuropathy. And this was more as a bridge as we kind of went on to something we thought would be a little bit more appropriate for her, which was CAR T therapy. That newer immunotherapy that has approval now from the FDA and has been effective, which doesn't necessarily require any subsequent treatment once the cells are received, just management of any issues that come afterward. So I hope putting this into context with some patients and patient scenarios has made this a little bit more understandable. I know this is, just a really, it's amazing and also overwhelming. It's overwhelming for even those who are practicing it because there are just so many options. It takes a lot of forethought as to what works best for an individual. We have all this data, we have all of these large clinical trials, but when you're there sitting with an individual with one patient, you have to pick what's right for them out of that entire menu, and it's a challenge. And so speaking with patients, understanding their values, and then also understanding their medical issues can help, and then also what their long-term goals are. So it's really hard to know now with all of the treatments that we have if they're going to compete with each other or they're going to work together. And if we see some of the newer therapies that we are using, oftentimes they're investigated in people who are in later lines of treatment. So all of the immunotherapies that I've discussed, most patients had already been through some of those earlier treatments, like the proteasome inhibitors, the IMiDs. So as we try and build upon that, we move those immune therapies or those later therapies earlier into the treatment and often add them to existing regimens, which sometimes makes sense, but I think people are starting to rethink that. Why do we necessarily need to add one treatment to another if there's no mechanism that really supports doing that? So like I said, this is kind of changing. And for example, where things are going to be heading in the next 5 to 10 years, we're going to be testing CAR T cell therapy. Somebody drawing on my
Yeah, I don't know what's going on.
That's interesting.
They shouldn't be able to, so I don't
That's
know.
funny. I guess they didn't like the slide. So we're going to be there are going to be clinical trials looking head to head CAR T cell therapy with transplant. So that's going to be very interesting and maybe provide a change to the way we do things 5 to 10 years from now. But I have to say, just seeing where myeloma therapy has come from just over the past 20 years and how things are exponentially improving, I think the treatment options for myeloma therapy already are very, very bright, and it's only going to continue to improve. So as I said, I think myeloma is a curable disease. We just haven't necessarily found those have already received that cure. So I'm excited to be part of it. I'm excited to see where it's going. And so I'm really appreciative once again for the opportunity to present, to talk with you all, hopefully provide some education, and hopefully you feel a little bit more empowered as you go through your treatment. I'm really fortunate to work with an amazing group of colleagues here and then at my other institutions that I've worked at. I put this quote here, I think we are standing on the shoulders of giants, and it's not really the investigators. I think of course they have an invaluable portion or part of the development of some of these drugs, but it's really the patients who have participated in some of these clinical trials who have not only sought to try and help themselves, but have participated in helping other people, people they'll never meet. I think that's incredibly valuable and incredibly selfless. So I commend them. And I think because of you all, because of patients such as yourselves and the support and families that you all have, myeloma is going to be a disease that we will cure. So I once again appreciate the opportunity to present to everybody. I would happily take any questions. If you want to write them here on the slide, I guess you can.
No. Oh my goodness. Thank you so much, Dr. Goldsmith. And we're still learning to get to know Zoom. So my apologies for that. I'm trying to figure out how to turn that off, but I'll just stop your screen sharing, and then hopefully that doesn't happen again. Thank you so much for your presentation. I felt like it was extremely clear what you were presenting, and I loved the patient experiences that you used at the end so that we could see how it could be used in real life. I want to share just really briefly how people are able to virtually raise their hand. Unfortunately, if you raise your hand in the camera, I won't be able to see you or recognize you, so you'll need to do it this way. You're welcome also to enter your questions in the chat if you feel more comfortable. I do see some questions that we'll get to in the chat, but if you want to ask your question directly to Dr. Goldsmith, you can do so by clicking reactions at the bottom of your screen and then clicking raise hand. You can also, if you're on a tablet, click that more button with the 3 horizontal dots and then click raise hand, and that way we'll be able to get to you and call on you so you can unmute yourself and ask your question. I wanted to start with a couple questions. I see, like I said, questions in the chat that I think are excellent that I want to get to, but I had a question that I've heard from patients regarding, like, do all, for example, PIs, proteasome inhibitors, do they all carry the same side effects? We know that Velcade is carrying, neuropathy. Are other classes of drugs, are other drugs in this class also neuropathy instigators, I guess, as well?
Yeah, it's a really good question. There are some overlapping side effects. I think the effect on blood counts is probably overlapping, but then there are some that are different as well. I think the neuropathy is, it's more seen with bortezomib or Velcade. It's still occasionally seen with some of the other proteasome inhibitors, such as carfilzomib, maybe a little bit more with our ixazomib. With carfilzomib, you think a little bit more about potential issues relating to the cardiopulmonary system or heart and lungs. It occasionally can lead to issues with the heart function. So I think that's something that you take into account when you are deciding whether to put a patient on that or Velcade. And the some of the side effects, such as occasional fatigue, seem to be more class related across the class.
Awesome, thank you. And the same type of question, are the risks the same for the same class of drugs? So for example, we just had a session last night about the secondary cancer risk that comes with Revlimid. Would that same risk occur in Pomalyst since they're in the same class of drug?
I think theoretically, yes. The issue, though, probably more so is the timing of when it's used. So we think of with Revlimid in general, the secondary risk of cancer or risk of secondary cancers probably more so in the post-transplant maintenance stage, which is really, and I saw the chat question too. Revlimid is more used than the other immunomodulatory drugs in the post-transplant maintenance stage, whereas something like Pomalyst, not so much. So the amount of time that you're using it, as well as what it's been sequenced behind, probably impacts that risk of developing a cancer more so, I would think, than the drug itself. So I think theoretically, if you were to use Pomalyst after transplant, it would probably carry the same risk, like immediately post-transplant maintenance. But I think in other scenarios, probably to a less extent. But we did see that with with the same issues with thalidomide. So it seems like it's probably more of a class related.
Okay, awesome. Let's get to some of the questions in the chat and then I'll continue with my questions because I could have you talking here all day. Sydney was wondering, you were talking about that new clinical trial with radioactivity. Is that commonly used in myeloma or would this be something new? I mean, what? Yeah.
So radiation therapy is very commonly used in myeloma.
That's what I thought. Okay.
So we use like external beam radiation therapy to treat symptomatic lesions, things that are causing pain, things that are causing, some type of potential urgent issue. It's very effective. It works very well on the spot that it's treating, but we don't have anything yet where we can deliver radiation to theoretically every myeloma lesion at the same time.
In the blood. Yeah.
So using the targeted radiotherapy that I talked about, that is the idea behind that, where we can take radiation, which we know is very effective, and then hopefully deliver it to as much myeloma as we can without having to radiate everywhere.
Yeah, because I was thinking, and that's a great question, Cindy. I'm glad you asked that. I was like, is radiation radio? I mean, now that I've said it, I realize it is. But it's interesting too, because when you were talking about the trial, I was like, oh no, they're going to get exposed to so much. But in the end, I think the end goal is they're exposed less because they're targeting myeloma cells instead of getting exposure everywhere, right?
Yeah, and that's the radioisotope that we're using is one that doesn't go very far. It goes only like into it basically goes into the cell that it's next to and doesn't spread beyond that. So that's the idea behind it, is that we're using something that's delivering a target or delivering the radiation, and then the radiation doesn't spread beyond that area that it was delivered to.
Right. Awesome. Thank you. And I'm excited to see how that goes.
Yeah. So,
sorry, one more question about that, just because we have so many people from California in the session today. Who is that open for? Like oh my gosh, what am I trying to say? What stage of journey do you need to be in? Those words
it's going to be, because it's a early phase trial, since it will be kind of a first in human trial. It's something that will be open to people who are later in their journey. We would like people to have, been able to get whatever we know is tried and true before trying to bring this. But hopefully, if it's effective, we'll be able to provide it earlier to other people.
Yeah, that's exciting. Well, good luck. Greg has a couple good questions. One of them is, how long does it take to manufacture? You mentioned that is something to consider. How long does it take to manufacture those CAR T cells? And then can you briefly explain for our newly diagnosed patients, I said newly twice, what is the difference between stem cell transplant and CAR T therapy? Because sometimes those get mixed up as they hear about CAR T.
Definitely. That is, both are using cells as some form of treatment for myeloma. I'll start with the stem cell transplant. So the stem cell transplant, what we do is we give a patient medications to push their own stem cells, their blood producing cells, into their bloodstream, and then remove them from their bloodstream in a procedure that kind of looks like dialysis. And then we take those stem cells and put them off to the side in a freezer to hold on to. Then a few weeks later, once a patient's recovered from that, we would have them admitted to the hospital and give a high dose of chemotherapy, that high dose of melphalan that I spoke about. And the reason we do that is because we know that melphalan is very effective at killing off a lot of myeloma. And it works very well. It's tried and true for years now. The downside to using that high dose of chemotherapy is that it also kills off the remaining blood producing cells or stem cells that are still in the body. So fortunately, in the freezer, we have the stem cells that we collected from a patient, still there. And so a day after the chemotherapy, we can give back a patient their stem cells. And so that is the type of stem cell transplant that we use in myeloma. They're really the main purpose to be able to give a high dose of chemotherapy. We use that at a different time point than we would use CAR T cell therapy. CAR T cell therapy is for people who have gone through a number of different treatments. And in that case, what we're doing is we take a patient's own T cells, those immune cells that I spoke about, in a procedure that actually looks very similar to how we get stem cells out. We then take those T cells and send them to one of the commercial manufacturers. And it takes, at this point, about between 4 and 5 weeks for them to genetically engineer the cells, expand them in the lab, and then send them back to us. So that is I think the question that Greg was asking, how long does it take to do that? It's usually about 4 to 5 weeks. And so we get these genetically engineered T cells back, have a patient admitted to the hospital. We give a low dose of chemotherapy to actually make room for the CAR T cells and to prevent those CAR T cells from being rejected. And then we give the CAR T cells to the patient. And so one of the key differences between a stem cell transplant and the CAR T cells is that in the stem cell transplant, the cells you're receiving, they don't fight the myeloma. They're just there to support you after you've received chemotherapy. The CAR T cells are engineered to fight the myeloma. So that's kind of one of the key differences between them.
Yeah, that's that's one of the best explanations I've heard, Dr. Goldsmith. Great job. Thank you so much for that. Eileen is wondering, often these, I was going to sound cool and remember what they're actually called. Biphosphonates, maybe?
Bisphosphonates, yeah.
Something, I was close.
Mhm.
Xgeva or Zometa, is that technically part of the multiple myeloma treatment? Is it just, talk to us about the role of those.
Yeah, it depends who you're asking. Some would say that it's just there to support the bone health of the bones that have been affected by the myeloma or could be affected by myeloma. But we also know that there's the bisphosphonates like Zometa or the other newer drug called Xgeva. They actually do inhibit some of the signaling of the bones to the myeloma cells. And at least in the laboratory, we've seen that it prevents the myeloma cells from seeding in new areas. So it really is kind of an integral part of the myeloma treatment. It doesn't directly kill myeloma cells, but it probably does disrupt their ability to go from one place to another. And so they are important aspects of the treatment, no question.
Interesting. That's great.
That was a really good question too.
Yeah. These questions are awesome. One of my questions that I'll ask right now, are there several pharma companies working with bispecific antibody treatments? I mean, how many, as we're seeing multiple CAR Ts being approved, is that going to be the same type of thing that multiple bispecific antibody therapies are going to be approved for myeloma patients as well?
I think so. There are probably, I just wrote something on it. There's probably about 7 or 8 companies that are working on bispecifics right now. They all have their own different formulation, their own way of doing it. And what's also neat is that they have a number of different targets on the myeloma cells to go after. So even if one doesn't necessarily work, it's possible that others will. So
you see it as really a good thing that, I mean, not that it would be a bad thing, but it does have a silver lining that so many are coming.
Yeah, competition is good.
Okay. Sometimes I just get overwhelmed for my patients and caregivers that they have to navigate so much.
There's a lot to choose from.
Yeah, definitely. Kimberly's wondering, does having a stem cell transplant increase further risk for other blood cancers? And we talked about this last night as well. Does the high dose of melphalan increase risk for other blood cancers?
The risk is there, but it's relatively low. I don't have the exact numbers offhand. Anytime you are giving any type of chemotherapy, there are, it does pose the risk of causing mutations in normal cells, because it does cause damage to the DNA. I'll have to get back to you on the exact numbers, and I know.
Well, yeah, I can send out the recording actually from last night where he went into detail in that. So
okay, good.
Yeah, no worries about that. I can make sure that they have access to that recording. Okay, this is another question that I had, so I'm glad that Mike asked it. Okay, let me find. So I'm going to kind of combine two questions. Todd asked a question about quadruplets and induction therapy, and then Mike's asking a question about maintenance therapy. So hopefully my question makes sense. The first half of my question, has DARA been tested with CyBorD? And then my, top part of Todd's question fits into that. Is quadruplets now standard as induction therapy? Even for those with kidney involvement, I guess, is my question.
Yeah, so very good questions. DARA has been tested with CyBorD in a phase 2 study, which it looked almost equally effective to its combination with RVD. And then it's been tested in patients with amyloidosis and is actually an FDA-approved regimen for amyloidosis.
Interesting.
So we know that it's a very effective combination as well. Some even wonder if it actually, the addition of DARA. So we know, at least from prior trials, that Velcade, Revlimid, and dexamethasone is generally considered better than CyBorD. But some are wondering, if you add DARA to both, does that make them equal? And we don't have that study yet to say that, but one could expect that there's a chance. Using it in patients with renal dysfunction and kidney issues, it's a little bit, I think some physicians will do it, and some physicians will just add it in later after we've achieved some level of kidney recovery. Probably the reasoning behind that is the addition of DARA to any regimen does introduce risks potentially related to infection. And patients, for example, who are on dialysis or have bad renal dysfunction are probably at a little bit higher risk. So that's kind of practitioner dependent. And then the question regarding have quadruplets become a standard in the right patient? Yes. I'd say in a patient who wants aggressive treatment, relatively young, fit, probably going to go to a stem cell transplant. Most myeloma practitioners are using that now. But others, you could still, there's class 1 evidence for both that or RVD, just a triplet.
Right.
And so you can easily justify either.
Interesting.
And I think in patients who are a little bit older, or who have any type of medical comorbidity, or maybe want something a little less aggressive, using the triplet is definitely reasonable and justifiable.
Awesome, thank you. And then my second part of the question is, would you consider DARA as maintenance therapy for somebody with kidney involvement? And do we see DARA having less side effects than carfilzomib or bortezomib or lenalidomide?
Yeah, we probably do see less side effects than those novel therapies. And it would definitely be an ideal maintenance choice for some people. I think we do have a clinical trial going on right now with DARA alone as maintenance. And then another one going on with DARA plus Revlimid versus Revlimid alone, to see if it's a more effective maintenance. To my knowledge, DARA alone does not have the indication. It becomes we've tried it before to get DARA alone as maintenance, and it becomes a little bit challenging because that evidence is not there yet. But I think it's coming. So I would expect that some will be using it in the future.
Yeah, that's great. We've reached the end of our time here. Unfortunately, I'm sorry we could not answer all of those questions. We had great questions today and great discussion, Dr. Goldsmith. Thank you so much for your time.
All right.
Do you have any last statements you want to make before we leave today?
No, once again, thanks for the opportunity. Like I said, great to see familiar faces and new ones. And if you have any questions, feel free to reach out through Myeloma Crowd or whatever other avenue. If you're in the California or Southern California area, I'd be happy to see you virtually or in person as well. So thanks again, and I look forward to doing this in the future.
Yeah, thank you. We appreciate you so much. Join us next month on June 14th. We're going to be talking about the risk status in multiple myeloma, understanding fish and chromosomes. I'm really excited. I heard a presentation or a practice presentation of this, and it explained genomics and genetics in a way that I've never heard it before. So understandable, so accessible. So make sure that you're there to learn a little bit more with me on June 14th at 1 p.m. And then there's other upcoming events you might be interested in. On the 28th is our African American myeloma chapter. That's tomorrow. We're going to be talking about Revlimid, understanding that therapy, its side effects, its mechanism of action, its risks, etc., with Dr. Craig Cole. Then on the 3rd at 1 p.m. is our myeloma financial chapter. We're going to hear from the financial program manager, Diana Valentine, how to pay for those expensive medical bills, including how to recognize medical bill errors and fight those without going bankrupt. And then Wednesday, May 4th at 7 p.m. Mountain is our HealthTree Moves for Myeloma chapter. That's our fitness chapter. We're going to be hearing how Pilates can benefit myeloma patients. The link to sign up for any of those events and even more events I have not mentioned today is found at the bottom of this slide and will be included in our follow-up email, along with those other resources I've mentioned throughout. I did have a question. I did see a question in the chat. If you want to send your questions to me that weren't answered by Dr. Goldsmith at this time, but you'd like to get them answered, you're welcome to email those to me. I'll put in my email now to everyone. It's audrey@healthtree.org, and we can make sure that those get to Dr. Goldsmith when he has time to answer them. And then, as always, I would like to thank our sponsors without whom this would not be possible: Bristol Myers Squibb, GSK, Genentech, Janssen Oncology, and AbbVie. And thank you so much for helping me build this community. I appreciate you and hope that you have a great rest of your day. Thanks, everyone.